Honored to have Dr. Steve Carstensen here. Dr. Carstensen is well known as a leader in dental sleep medicine in the United States and around the world. And also, I have the privilege of being on a task force for pediatric sleep for the American Dental Association with a number of other people who are here, like Kevin Boyd. But thank you very much for taking some time in your busy schedule here today. Thank
Absolutely.
you.
Well, I am the shortest one he's invited to lecture. Okay, I'll wait, because I only got 10 minutes. So you done here with the signs, you can start now. I loved that slide from the one you had about the interdisciplinary team there with all the different people and all the arrows going everywhere. That's perfect. ADA has a lot to learn from you. Mark asked me to talk here because a year ago, Kevin Boyd and I and a couple of others put together a conference at the American Dental Association headquarters about sleep-related breathing disorders for children. And what was extra cool about that is that, I have no disclosures about anything here, is they made a policy statement a couple years ago, 2017. First time the American Dental Association has ever made a policy statement that embraced more than just dentistry. And so they reached out and said, okay, we got to be involved with medicine here a little bit. And although they've paid kind of lip service to the crossover between oral health and the rest of the body, they've actually made steps to make this part of dentistry now. And it's really, really important. And out of all of that, they had 11 policy statements in this whole document. And 10 of them are about adults, and those are wonderful. I love treating adults. But one of them is a game changer, and it's this one. And it's the second one that they put on there. It's about children. Says a lot there. We're not going to go through all that. But most important is a clinical exam may identify signs and symptoms of deficient growth and development. Didn't talk about signs and symptoms of OSA, of sleep-related breathing disorders even. Deficient growth and development. One of the things I think we ought to do as dentists is we ought to move away from relying upon the diagnosis of OSA or AHI or that as the primary diagnosis. I think the primary diagnosis is underdevelopment of the craniofacial respiratory complex. It's poor muscle function. That develops as that spiral you shows down at the bottom of the spiral is OSA. Let's get after it earlier. And this document here from the policy statement says that we can do that. And then it talks about later about development of an optimal physiologic airway and breathing pattern. Not about elimination of OSA, but an optimal physiologic airway and breathing pattern. That's what we need. You can't do that with just growth and development. You have to do that with properly training the tissues to function well as well. So, Guilleminault, he's been quoted by every speaker I've seen so far this past 2 days, and all the ones I've seen in the last 10 years of doing this. Our study evaluates the impact of myofunctional reeducation in children with SDB. Important stuff, right? So if dentists are going to fulfill the policy statement requirements, they must evaluate, diagnose, and facilitate treatment to optimize children's airway. It's not about what we're going to do as dentists, it's about how we're going to facilitate optimal treatment. The earlier slide today talked about how pediatricians are going to be our primary drivers, the first line treatment. How many kids see primary care physicians for airway related issues? They see them for other issues. They get 7 minutes per child. In dentistry, we get over 60% of kids in the United States see a dentist every year. And if we train dentists and dental hygienists to be important first-line recognizers of problems, now we can start to enlist the rest of the team involved. We have to earn our way into that pyramid you showed. You didn't put dentists on there because we're going to be on there later on because, as you said at the break, you said, look, I kind of think about you like primary care doctors. But until we put the language in, it's not going to be the best known. It's not going to be the position we can take, and that's what I'm going to work with the ADA. So there's that policy statement, but they also put in their evidence-based treatment. Obviously a challenge for lots of things. We've talked about whether we have RCTs or observational studies or what else can we do to go to the American Dental Association and say, look, we're going to do this with evidence. So we're going to gather that, and the work that's been done in France and other places we can use for that purpose as well. So I'm happy about all these things. We have to have a bigger airway, but we also have to teach them how to use the bigger airway properly. And I think dentists are going to be amazing resources for that. And it's every breath, you know, every swallow, it's every function of the airway. Now, OSA is going to be something we'll do, but I think, in my view, OSA and AHI are residual thought patterns. It's because AHI was the first thing discovered. It was OSA in adults. It was OSA in overweight old men. And then they think about the physicians, the people that are gatekeepers, looked at that and said, well, okay, let's apply that to younger and younger people. We think about AHI in young adults. We think about AHI in adolescents. We're even thinking about AHI in kids. But now more and more papers are being published that say that how do you measure an AHI in kids is very unreliable. We don't get good numbers out of pediatric sleep studies. There's only a few of them out there. That was shared earlier too. And so I don't think it's going to be about AHI in kids. I think it's going to be about growth and development. It's about myofunctional therapy. It's about how the body works the airway system. Now, what's the good news from the American Dental Association is that they're paying attention. They want to do something about this. They want to enlist 198,000 dentists as part of that team. And out of that 198,000 dentists, most of them, whole bunches of them, employ dental hygienists, employ 2 or 3 dental assistants. We have hundreds of thousands of people that can pay attention to children's airway, and they have no rules yet. They don't have to overcome bad behaviors because the dentists haven't been trained in this. We've been trained a little bit. Some of us have been trained in adult airways. Very few of us have been trained in pediatrics. So as we think about now, how are we going to take an American Dental Association that's interested in this, interested enough to put on conferences, to put on workshops, to make policy statements. They're craving information. People in Chicago tell me that, look, what do we do? So we get to bring all of this new information and from a clean slate of paper, we can create a workforce to help make a difference in children's airway. That's going to be a huge, huge benefit to all of us that are so passionate about this. Take all this work that's being done and put it in the hands of an organization with a multi-million-dollar budget and interest, researchers, people that can go through 5,000 sleep tests by hand. Oh my gosh, let's do that and let's make a big difference. And that's what the ADA can do. They're listening, they're paying attention, and we're going to make this happen. So the ADA House of Delegates just 2 weeks ago passed a resolution that says we're going to make a children's screening tool and protocol. Well, do we need a new screening tool? Maybe, maybe not, because I heard about several of them. Maybe there's great ones out there. The ADA doesn't say they're going to write a new one. They're going to say they're going to create one and publicize it to the rest of the profession. That hasn't been done before. We haven't had an organization take our tools that's been worked up by great people and publicize it to an entire profession. So we're going to do that. That's what ADA is going to start doing starting soon. So we got that going for us. Did I make my time?
It's exciting stuff.
Absolutely.
So.